Right, so in this video, I'm going to be talking to you about epidural anesthesia. And what we're going to discuss is what an epidural is, when it is good to use one, when you would prefer to avoid it, the benefits of an epidural, the drawbacks, the alternatives, and of course, the timing. Now, I know for a fact that many people just think epidural is the bee's knees, the snake's hips, the cat's pajamas. I mean, why would you even consider having a baby and not have an epidural, which essentially takes away all sensation from just below the breasts right down to the toes? I mean, sounds like heaven. The drawback to that is that it actually cuts off your entire feedback mechanism. But there are times when an epidural can be really beneficial. Essentially, what an epidural is an injection into the epidural space, which is a space in the spinal column, and we inject a local anesthetic that numbs all the nerves that supply the entire pelvic region. It is done by an anesthetist. You need to sign consent, and it is an intervention, and it's quite a big intervention. The drawbacks to an epidural is that essentially, like I said, it cuts off your feedback mechanism, and it does make you a passive participants in your birth. You're unable to actively move around and respond to what's happening in your body because that entire sensation pathway has been taken away. It also means that you're unaware of the movements of your baby and the feeling of your baby in your belly. So there can be a disconnect, which is just something to bear in mind because you can still stay mentally connected to your baby. If you've been in labor for like 24 plus hours and you're absolutely exhausted, an epidural is like a godsend. It's amazing because it gives you an opportunity to get some rest. And if your labor has gone on for that long, the chances of them doing an augmentation using synthetic oxytocin or pitocin are very high. And what happens when you have that, we call that an augmentation of labor. We are speeding things up synthetically. But what happens is that those sensations can be quite intense because we're using the synthetic version of your own hormone, oxytocin. Now, when your body releases your own hormone, oxytocin, it does it in a way that little bursts and gradually your labor sort of picks up and increases in intensity over a period of time. Now, if that hasn't happened and your labor is just kind of putted along for hours and hours and hours, you need a little bit of help. We give you the synthetic version of your own oxytocin, but we give it to you in a measured dose. So rather than it taking hours, we are literally bumping up the dose, starting with maybe 3 mils an hour. Half an hour later, we bump it up to 6, then we double it to 12, 24, and so it goes until we get the pattern that we need to see, which is surges that are happening at least every 2 to 3 minutes and causing changes in your cervix. Now, because it's just a synthetic version of your own oxytocin, it doesn't cross the blood-brain barrier like our natural version does, and your body doesn't have the same response of releasing endorphins, which are our own pain-relieving mechanism to help you to cope with that. So when you hear people talking about an induction being more painful than a naturally occurring labor, that's what they're talking about. However, if you've never been in labor before, you have nothing to compare it with. And the reason that we offer you pain control medication and techniques when you're having an induction is exactly for that reason. So that's why those are available to you. So keep an open mind as to what you would like to use. In a normally progressing labor, if you're requesting an epidural, we always recommend that you wait until you have an active labor pattern. What does that mean? That means that you're having at least 2 to 3 surges in every 10 minutes. Your early labor, which is when there's no pattern, there's no rhythm, has got to a point where we now do have a rhythm. And every 2 or every 3 minutes, you are having a good surge that requires that you breathe through it. You don't want to speak through it. And it's pretty intense. You need to be in that active labor pattern. If we did a vaginal examination at that stage, you would probably be at least 4 to 5 centimeters dilated. So you're kind of halfway there. Now, every woman is different. So some women might get there within 4 or 5 hours. Some it may take 12. Some it might take 24. But depending on how you are managing when you get to there, if you're needing that extra little bit of help, And today we're speaking specifically about an epidural here, and you need that level of pain management that takes away everything and gives you an opportunity to rest, then an epidural would be a good option. Like everything else, it's always good to talk about the benefits, the risks, the alternatives, and the timing. The benefit of an epidural is that it literally provides 10 out of 10, 100% pain relief. It's an opportunity to rest if your labor has been particularly long and is not progressing as expected. And if we talk about your pain scale and 10 out of 10 being like the worst that you can experience and unmanageable beyond that, then you would be at that 10 out of 10 label. The drawbacks or the risks are the fact that if you don't have what we call a mobile epidural, which allows you to move around, or if the mobile epidural didn't work as well as what it should have, that the dose was a little bit larger than expected, you would be confined to bed, unable to move freely and respond to what you're experiencing. The drugs that we use for an epidural naturally lower your blood pressure, so you might have that response where you feel a little bit faint, a little bit weak, which once again would cause or mean that you need to be in bed. It also means that we want to be monitoring your blood pressure. So along with being in bed, you're going to have a cuff that is around your arm, and that will automatically inflate usually every 30 minutes, but depending if you're responding well, it'll be every 30 minutes, so we can monitor your blood pressure. And because of that drop in blood pressure, we want to manage your fluid levels. And on the other side, you're probably going to have IV therapy, where before you even administer the epidural, we would usually load you up with a liter or so of fluid to manage that lowered blood pressure response to the epidural drugs. It can sometimes slow the labor down. The drawback of that is that we would give you drugs to speed it up. And the drawback of those drugs is that they might cause fetal distress. So it's all about that cascade of intervention. It does increase your risk of other interventions like a von Tu's birth or vacuum we talked about, because you don't have the sensation to push. You can't actually feel what's going on as your baby moves out. There's no urge to push, there's no pressure, there's nothing. It's a bit like, you know, when you go to the dentist and you have a local anesthetic in your mouth, you try and drink and it kind of dribbles out. It's a bit like that. You know how to drink, you know how to swallow, but there's no sensation there. And that's what it's like when you have an epidural. Because you cannot feel anything, the other intervention we are going to do is we're going to insert a catheter into your bladder. So that also kind of confines you to bed, limits your movements, so that's continuously draining and keeping the bladder empty. Because remember, with the proximity of your bladder and the baby's head coming down, it can get in the way if your bladder fills up. So we want to make sure that it stays empty. If you don't have an epidural, you will naturally feel when your bladder is full, and you would continuously be walking to the bathroom to empty it. About 1 in 100 women get a headache after an epidural, and it either resolves spontaneously over time or with lots of fluid, and surprisingly we give you caffeine, which helps. But if not, it means that you have to have another epidural where we go in and almost reverse that. Your back also might be a little bit sore for a day or two afterwards, but this is not necessarily from the epidural. It's usually because you can't feel to move, and you might find that you lying in one position for several hours. So it's really important, if you have an epidural, that your partner or your doula makes sure that your body is well aligned, lying straight in the bed, and that they assist you to move to your side every hour or so, and to keep moving you into different positions so that you don't get that stiffness or twisted or cramps that you wouldn't feel because you can't feel anything. Of course, the alternatives that are available to you instead of an epidural are all the other pain medication options. The other medical ones being pethidine, which is the intramuscular injection that takes about 20 minutes to work and lasts for 4 to 6 hours. And I've spoken about that in another video. The other alternative is the gas and air. Those are your 3 medical alternatives, or the 3 medical options that are available: epidural, pethidine, and Entonox. And then, of course, there's many non-medical options that are available to you: the TENS machine, breathing, movement, massage, your doula, warm water, light touch massage, visualization, focused, internal focus. I mean, breathing alone has got at least 5 different breathing techniques that you can use. So there's many non-medical techniques that you can use. However, if you're going to use those, and if that is your preference, it is vital that you start practicing those during pregnancy. Don't read about them and think, oh, I'll know what to do when I'm in labor. You really do need to start practicing and employing those while you are pregnant, and I highly recommend that. In terms of the timing, as I mentioned before, you need to be in an active labor pattern with steady and rhythmic surges. And the best time usually, or the window of opportunity for an epidural, is between 4 and 7 centimeters of dilation. If we do it too early, your labor could slow down, stall, requiring other interventions. If we do it too late, there's a complete lack of sensation, which could interfere with your ability to push. So those are just a few things that you want to be mindful of when it comes to making your decision around having an epidural. I think the most important thing for me is to bear in mind that it is an intervention, and any intervention is a step on the cascade of interventions. So it isn't the silver bullet that it is spoken about as being. It isn't the one thing that is just amazing, takes away all sensation. That in itself has implications. So think about those implications, but also don't let that put you off. If you're in a situation where taking away all sensation and giving yourself an opportunity to rest could be beneficial and could get you the outcome that you desire, then it might be the right decision to make. And a good example of that would be a labor that progresses for much longer than expected. So a long latent phase in excess of 24 hours, and then a long active phase, in which case you've been awake for 2 or 3 days. If you could have an epidural that gave you an opportunity to sleep for even 6 hours, it might give you the energy that you need, and you could still get that vaginal birth if you had a patient and understanding care provider, and of course, if there wasn't any other factors that were holding that labor back, or if there was no reason for that long stalled labor, and of course, if there was no fetal distress. Always comes back to asking the questions, keeping the communication open, and getting that open line of communication between yourself and your care provider. And as always, if you have a doula, using your doula who will guide you to ask those questions, and will certainly also guide you around the timing, because your doula knows your preferences. Hope that helps. Enjoy that, and make sure that you read the supplementary material that we've got on epidurals.